Hello, welcome to the Building Blocks of Infection Prevention and Control. This telementoring series is a part of Project First Line, CDC's National Training Collaborative for Infection Prevention and Control. In the AMA's work with Project First Line, we have heard from physicians that there are significant challenges in facilities outside the acute hospital setting, places like ambulatory surgery centers, pediatric offices, and behavioral health centers, to name a few. To help meet these challenges, we developed this telementoring series, bringing in physicians from these settings with IPC experts from across the country. This session will focus on some IPC questions that can arise within behavioral health centers. These facilities have inherent challenges. Group therapy and social interactions are an important component of patients' treatment plans, and isolation can be very detrimental to these patients. Enforcing usual strategies like masking can be quite difficult. Before I move on to the case presentations and what is sure to be an interesting discussion, I'd like to remind everyone that the opinions expressed in this session are those of the presenters only and do not necessarily reflect the official position of the American Medical Association, U.S. Department of Health and Human Services, the Centers for Disease Control and Prevention, or the presenters' affiliated institutions. We do have some ground rules to cover. First, this is a share all, learn all format, so judging is not appropriate. It's okay to disagree, and those disagreements can lead to great discussion, as many of these cases highlight some great areas of infection prevention, but we want to make sure our words and language remain respectful. For those of you joining in chat and asking questions, please introduce yourselves and highlight the state you work in and whether you are a physician, nurse, therapist, or other occupation. We want to tailor our answers to what is most helpful for you. And lastly, please do not put any PHI in the chat. Just keep questions general. Next, I'm honored to introduce the panel we have today. After the introductions, we'll go through an overview of the cases and discussion, and then we'll end with some CME information. Now, our first presenter is Dr. Jeffrey Fetter. Dr. Fetter is a board-certified internist and psychiatrist and is Chief Medical Officer of New Hampshire Hospital, the only state hospital in New Hampshire. He is an assistant professor at Dartmouth's Gesell School of Medicine and has practiced in community corrections and inpatient settings. Earlier this year, the National Alliance on Mental Illness named Dr. Fetter as an exemplary psychiatrist, one of only 4 named in 2023. Our 2 subject matter experts are Dr. Rama Thiagarajan and Dr. Catherine Passaretti. Dr. Thiagarajan is an infectious diseases physician with special clinical interest and expertise in infection prevention and antibiotic stewardship. She is currently the physician lead for infection prevention and antibiotic stewardship at Dell Seton Medical Center at University of Texas at Austin, a role she's held since 2019. She was previously the corporate medical director of infection prevention at Beaumont Health, the largest multi-hospital health system in Southeast Michigan. Dr. Passaretti completed medical school, internal medicine, and infectious disease fellowship training at Johns Hopkins. She currently is vice president, chief epidemiologist for Atrium Health, and is a clinical professor in internal medicine, section for infectious diseases at Wake Forest University School of Medicine. Now, I'm excited to move on to our cases. Case 1 is an interesting case. We have let me go back and send the presentation over to Dr. Fetter. So let me start again. Now I'm excited to have Dr. Fetter present our first case. Dr. Fetter?
Thank you. Our first case is a 45-year-old woman with schizoaffective disorder presenting to the emergency department with severe depression in a depressed phase. She's been in the emergency room alone, except for staff, for the last 7 days, waiting for a bed to open up in the state hospital. She's been cleared medically and has no symptoms beyond her depression. However, she refuses a screening COVID antigen test in the emergency room. Should we insist on the test? And should she go into admission quarantine at the state hospital? And if so, how long?
These are great questions and not ones that we had to deal with before COVID. COVID brought in a lot of really challenging IPC issues with a lot of post-acute care hospitals implementing routine COVID screening on patients. Dr. Passaretti, I'd like to see what you think about this patient who refuses screening, but really needs admission to the psychiatric hospital.
Sure. I do think that during the height of the pandemic, certainly most behavioral health locations were testing prior to transfer. As we exit the pandemic, it's prime time to evaluate like what makes sense in what setting. So I would say generally, yes, prefer that patients either get tested or quarantine. But I think that the firmness of that answer and flexibility on that answer depends on how much COVID transmission is going on in the community. We have several behavioral health facilities in my health system, and have found relatively low yield from testing when there's low amounts of COVID in our system. So, the amount that you push to get that testing done or quarantine, we've started to have a little bit of flexibility with that. So I do think, keeping an eye on the COVID rates in your community may impact your answer on that question.
That's great. Dr. Thiagarajan, what do you think would be a way that these types of facilities can monitor the COVID levels? I think it's nice to say like what's going on in the community, but how do we know what's going on in the community? What are some ways that we can follow that?
Certainly, that's a very good question. I think it's really the CDC has a lot of resources. So I usually use the CDC website, which is updated weekly during the peak flu season. And so you can go to links and look at your state and even county level information. So they look at, patients coming to the emergency room. There's different indicators, hospitalization, flu-like symptoms. So that's probably what I would look at. And I want to just add to what Dr. Passaretti was saying is this issue that was brought up really in regards to assessing community risk and making individualized decisions, which we can get bogged down because we're looking at this, it's templated. So it's good to look at it not only for the COVID pandemic or the COVID cases, but also with the large outbreaks of influenza, because there are some seasons we have very high activity, whether it's RSV, influenza, or some other novel influenza strains that bring about very severe illness. I just want to make a point that this principle is applicable for many other infections. So again, to go back to your question, really, I would look at the CDC. I don't know if Dr. Passaretti or Dr. Fetter has other resources.
Yeah, I think CDC and states often have kind of state level data. It'll vary from state to state. And if you're associated with a healthcare system or a healthcare system in the area, they may have information that they kind of keep an eye on that would be worth sharing. So I think there's a couple of, but totally agree, CDC, is one-stop shopping for kind of general trends and whatnot.
Yeah.
We certainly followed hospitalization rates in the state, and especially hospitalization rates of our local acute care medical hospital. And they report out on the internet how many patients are actually receiving remdesivir. And when that starts to go up, we start to get concerned, of course. The other thing that's kind of contextual on this is the vast majority of cases that we have in our hospital, if you do the case testing, follow the line listings, they're mostly from staff, not new patients being admitted. So it feels like it's low yield, and yet sort of politically, in a way, the staff wants to know that they're being protected, that we're doing the screening. And so we have these discussions to figure out like how strict to be.
I think that's a good point. I mean, it's not only protecting, staff from patients, but also protecting the patients from the staff. So those levels also can inform what to do when, community numbers are high, are those things that you need to implement discussions with staff about vaccinations or masking or those kinds of things. Dr. Fetter, did you have any experience with perhaps using something like wastewater testing or other modalities that that might inform outside of just the CDC's influenza-like illness tracking?
Yes, we implemented a wastewater testing procedure with the University of New Hampshire, that we would test the water. First, it was just single sample of like a tube of water twice a week. And then they started putting indwelling swabs. So it was absorbing the sample over the course of 3 or 4 days. And that would be twice a week as well. And that was thought to be a little bit more sensitive. And so if we saw a increase in the wastewater and we knew that there were a couple of staff who were on a particular unit, who are positive, that we might offer testing to asymptomatic patients on that unit or have a lower threshold to test patients with very mild symptoms. It really just changed our pretest probability of how to look at what folks we were getting.
Dr. Passaretti, you sort of said it's important to look at, what's going on in the community. If there is a larger, not necessarily even an outbreak, but you just start to see these numbers going up. For a patient like this that says, you know what, I don't want the testing, I don't want any part of that. In that case, would you say, let's try if we can to quarantine she's already been in the hospital for a week, so we sort of have had her quarantined there for a week. But should we do a couple more days in the behavioral health facility then?
Yeah, I think if there's a lot of transmission in the community, it's a setting where you're concerned about transmission, then, the potential for quarantine for that full 10 days to make sure no symptoms develop probably makes sense in the instance where someone refuses testing. The other thing I would say, just kind of reflecting on the testing part, I know this patient refused it, but if someone does get tested, where I've often seen challenges in behavioral health or, similar type settings, you take that test on admission as, oh, the patient's negative, I don't have to worry about anything. So I would just kind of reinforce, no matter what you test or quarantine or any of the above, you have to watch out for those symptoms and maintain that low threshold to test, because often that's, from either, as Dr. Fetter said, the staff kind of spreading to patients and developing symptoms, or vice versa, that can be the start of challenges in a unit. So just try to remind people of that as well.
Yes, the retesting is always an option if you think it's clinically necessary. Well, thanks. Let's move on to case number 2.
So second case is a 55-year-old nurse. She works at the state hospital, and she calls in to say that she tested positive for COVID-19 that morning. Upon further evaluation, 2 coworkers and 1 patient are also complaining of headache, fatigue, and rhinorrhea. What should the facility do now?
Dr. Thiagarajan, when somebody tests positive for COVID, they probably had symptoms before just that morning. So how do you look at, first, before we even look at the facility part, how do you look at one person and they get that positive test when they call in? How do you backtrack, or what do you do to sort of look at that bigger picture of who do we need to start from the unit standpoint looking at?
Yeah, I think each respiratory illness depends on, what is the incubation period. We learned from COVID generally when we think about spread of diseases from the time of symptoms, that the theme was different for COVID, where people were they were asymptomatic and then they were still highly contagious. So I would look at what type of diagnosis it is, and I would not again think, yes, COVID is still more severe, in a subset of patients. It's probably not. It's not in equal terms to influenza, but I still think we should think about respiratory illness and protecting our community, our healthcare workers very similarly. The themes are the same. So for COVID, given the fact that patients are asymptomatic, they can be asymptomatic and still be contagious, I would work backwards with this nurse and see when this nurse last worked. So if the nurse did not work the previous 2 days compared to the symptom onset, then I would start working up. I would I think if they already called you, then I think there is really no exposure. But I would be diligent and kind of look to see, did the nurse acquire this at work? Especially if there's community exposure, people spend 40 hours at work. So did the nurse acquire this at work or at home, and kind of ask and kind of dig into it a little bit and see if there were any household contacts. So if there's a household exposure, and that's true with many of the healthcare workers, people get it, they don't get it in the facility that they work, they get it outside the facility. Frequently it's a household contact. So, but I would be very careful and look to see where the contact was and be on alert to diagnose more cases. So I hope that answers your question.
Yes, thank you. I think that, we often think about, now I feel sick, and thinking forward, making sure that person doesn't come back in for X number of days. And we'll talk about that, but thinking backwards to say, when might the shedding have started? And, influenza is about 24 hours before. COVID's a little different. I feel like it's changed from the beginning to now, but Dr. Passaretti, what if Dr. Thiagarajan said, you know, if she hadn't worked in that last couple days, then you're in better shape. But what if she had? What if this is Thursday and she'd been working Monday, Tuesday, Wednesday now? How do you look at that, the rest of the unit then?
Yeah, 100%. And I think context matters, right? You're also telling me that there's a couple of patients or other teammates who are symptomatic. So in my mind, you're never wrong to say, okay, it smells bad, right? Like I need to go ahead and put masking into place on the unit while I'm testing individuals while I'm getting more information. So I lean towards kind of early intervention, and I can always back off if it turns out, you know, that's an isolated case. It was, you know, not real other cases of, and to Dr. To the point, like it's all respiratory viruses, not just COVID. But I tend to be aggressive on that front side if I get the sense that something is brewing, to try to abort the outbreak earlier. So I may not have all the data elements on the front side, and I think that's okay, but you know, putting in measures, and that may not be up to, you know, keeping everyone in their room, or you know, it may be a graded implementation of interventions to try to prevent spread on the unit as we get more information. But I do tend to at least put some initial either testing, masking, that kind of stuff into place early. And then of course, any symptomatic patients need to be isolated, you know, those very clearly, you know, while they're being tested and evaluated, need to be put into isolation. And that can be super tricky in the behavioral health setting, 100%, but trying to keep them out of the mix in whatever way is feasible for that unit.
I
Dr.
agree,
Fett,
if I may
oh, go ahead,
add.
Dr.
I'm sorry.
Thiagarajan.
Yeah, I may just add, I think I did not hear that, you know, there were two other, you know, healthcare workers. You know, I just want to bring up the point that in congregate settings, and typically the definitions that we're used to is if there is 2 cases, it's really an outbreak. So if there is more than one, you know, it's really an outbreak. So I would start, you know, looking into it carefully. How much I put in place really depends on, you know, the amount of contact and how sure I am about the diagnosis and a variety of things. And I fully agree with Dr. Passaretti. We do need to be aggressive. And this rule applies also to influenza.
Right. Dr. Fetter, in your facility, what would be the difference perhaps if one patient were symptomatic versus say 6 patients were symptomatic? Do you have the ability where you are, or I guess what's the difference if you have one patient, what can you do versus if it ends up being a larger amount of patients?
So we have evolved a sort of a level system where our hospital goes from level blue to green to yellow to red as our situation worsens. So at level blue, if we have one patient who is positive, we'll isolate them in their room, and for the most part, nothing much else changes. At level blue, there's not much masking. Masking is just optional throughout the hospital. It's the lowest level. If it looks like we're starting to have a bit of an outbreak, we could go up to level green, and then masking is required in patient accessible areas. So if you're in your own kind of administrative office space, you might not be required to mask, but anywhere a patient could walk right up to you, you would wear a mask. And the strategy is we got to keep ourselves from the staff from infecting the patients. That's the word. If we have 6 patients, we're probably going to consider being in level yellow, where masking is everywhere, and we start doing some social distancing measures. So groups are smaller, and our most vulnerable unit is our geriatric unit. So we take very particular care to make sure there's no mixing of patients with the geriatric unit to other units. And level red is no fun. And it's basically like, everyone please stay in your room best you can. And we've only luckily had to do that for something like over a week during the kind of overlap of the Delta and Omicron period, where it felt like half the hospital was sick. And that was a rough time. So that's our strategy, and that's how we address different levels of outbreak. And we also, in our policies, can respond using that system a little proactively if we see hospital overwhelm in our nearby medical acute hospital.
That makes a lot of sense. What was the response from staff when you implemented that? Did they they feel that it was, too dogmatic? Were they appreciative of the transparency of the different levels, or what was your experience when you implemented that system?
Yeah, we implemented it at first by doing a big Zoom with many people in the hospital and explaining it. We took a lot of questions. We took a lot of feedback that led to changes, and people felt pretty supported and supportive of the policy because it continued to respond to their feedback, because you can't think of everything. Reality and hospital operations are just too complicated.
That's so true.
And Dr. Fetter, do you I know in our facilities at times, like when we had significant outbreaks, we would almost kind of, in where geography allowed, put all the COVID patients in one area and allow for some interaction between those patients to do therapy and whatnot. I think there's different kind of solution, or have you found kind of different solutions to your like different layouts or different units to try to allow for, meeting those goals of care and therapy and all that?
Yeah, we tried a number of different configurations. It turns out one of the key factors on whether you stand up a behavioral health COVID care unit, in our experience, is the level of cooperativeness of the actual patients who are sick. So if you have a really cooperative patient, so if you have 6 really cooperative patients and they're all in one unit and they're willing to stay in their room, you can isolate them all very safely like that. But if even one of them is refusing to stay in their room, you might end up having to do seclusion and restraints on them to protect the rest of the patients. So if we were to have 6 positive patients and even just one uncooperative one, we have a 10-patient unit that we would empty out and move all the COVID patients in there. And we've got PPE and staff who are trained on the PAPRs and everything will all concentrate there. And that's been the most effective strategy of the others that we tried, including using parts of units or putting up temporary walls. And that just usually, the common problem with most of the other strategies is you end up with a staff member who is behind a infection barrier, such that if there's agitated patients behind that barrier, you can't get security to them fast enough. And they don't feel comfortable behind them, and for good reason. We were never able to solve that apart from using a whole unit. And again, at the very height of Omicron Delta times, the 10-patient unit wasn't big enough. We had to make one of our 24-bed units the COVID unit, and that worked fine as long as we had the whole unit dedicated to an isolation space.
I may also add that, when we think about, COVID safety for other patients and employees or healthcare workers, I think what comes up predominantly is face masking and social distancing, but infection prevention mitigation is multiple steps, right? You can ramp up hand hygiene, make sure everybody's hand hygiene, and then universal masking, which I think may be more acceptable, but even acceptable to the staff and not to patients, because patients may not be able to, may not want to mask or whatever it is. And also increasing disinfection and looking for populations, especially as you were talking about in the geriatric population, making sure everybody's vaccinated. And that's applicable again to influenza. I mean, if the outbreak is going to be slow and you might have some protection, if it's going to be really fast, it may not help. But looking at multiple other steps of mitigating, so you're cutting down the number of cases that happen in your unit.
I think that's a good point. I think a lot of infection prevention and control is recognizing that we can't be perfect on every measure or what exactly we would want to do on every measure. So if we can get the best that we can on multiple measures, that additive benefit really is there. Okay, let's go to our final case number 3.
So we have a 32-year-old man with bipolar disorder, currently in a manic episode, seen in the emergency department. His medical history is significant for daily tobacco use and hypertension. He is to be transported to the state hospital from the emergency department, but he tested positive for COVID-19 on arrival to the ED 5 days ago. He remains symptomatic with upper respiratory symptoms, myalgias, and is febrile but has no hypoxia. He's refusing medications, is quite hyperkinetic, and will not stay in his room without a security guard and intermittent locking of the door. what considerations drive whether he can come to the state hospital today?
Okay, so this is a tough one. I think it overlaps a little bit from our last case that we were discussing. Sort of the ability of the patient to cooperate with some of the measures that we might want to suggest. Dr. Passaretti, what would you think about if you get that call at 11 p.m. on a Friday night, because that's always when you get the call? Can this patient be transferred to Dr. Fetter's facility?
So this is a little bit different in that we know the patient has COVID, the patient is actively symptomatic. So generally, and I don't know that even if they got transferred to behavioral health while they're on isolation, that they would benefit from that setting. So often I have kept those in the setting where they're in until they're out of that immediate kind of isolation timeframe, symptomatically improved, not a risk to start an outbreak in that very sensitive setting, especially in a case like this where, it sounds like he's bouncing off the walls and not really able to be controlled in a behavioral health setting.
I would also be a little concerned, since he is febrile and not cooperative, that if this patient were to deteriorate, yes, given the newer, milder strains and many people are vaccinated, he doesn't have any risk factors for severe COVID. The fact that he's still febrile concerns me a little bit, and he won't be able to tell us if his symptoms are getting worse, like shortness of breath. Also, you kind of have to look at the patient's, what is his risk of getting worse, So I would agree. I would prefer to keep him in the hospital till I'm 100% sure that he is well enough to go to the unit and also at a lower risk. And when if you're able to retest him, you can use the COVID antigen test in patients like him when you're trying to make a decision whether they can go to the facility, presuming that the infectious disease doctor or the hospitalist is clearing him, saying that he can go to the facility. You can use COVID antigen tests. And if you can document 2 negative antigen tests over 48 hours, the CDC states that the patients can be moved to the facility. So that is another test that you can use.
Follow up to that, Dr. Passaretti. So some patients, as we know, clear their antigen test quickly and some do not. So if this is one of those unfortunate cases where, he's better, he's afebrile now for 24 hours, still not hypoxic, and some of those symptoms are improving, what would be your timeline, either with a positive antigen test or absent the ability to be able to get an antigen test, before you would say, okay, I think he's okay to go and be in that communal setting?
Yeah, just to comment on the antigen test, because I know in my facilities, we've had compliance, if you're not CLIA certified in a healthcare setting, like being able to actually do antigen tests. So those weren't often an option that we were able to use. We had to rely on kind of in-lab testing. So I would just say, talk to your compliance people about whether you can use antigens in that setting. For this kind of patient, I would wait the 10 days, full 10 days of isolation before I would kind of clear them to go to the behavioral health setting. I know there is a lot of confusion because generally now the messaging in community is, 5 days and symptomatically improved, no fevers, wear a mask, but you can go out and about. But I would say, healthcare continues to be different for all the reasons we've talked about. The risk of our patients, risk of outbreaks, that kind of thing. And, multiple studies have shown that COVID people can continue to shed viable virus, up to that 8 to 10 day mark. So I tend to still be conservative for patients going into a healthcare setting and sticking with that 10-day timeframe.
I think it's important to note he's very manic and he's not very cooperative, right? So chances are you're going to be going into restraints. People are going to be having close contact to patients spit, patients, on purpose or not. There's a lot of risk of contact with a fellow like this. And there's the ethical consideration as well, because you're going to be applying perhaps seclusion and perhaps restraints in a setting where you can't deliver any treatment. So, we thought through, and many institutions, I think, thought through the ethical ramifications of seclusion for quarantine and for isolation. And the way that we've evolved our view over time is to say that it's again based on that level system. So isolation, we consider you can use seclusion at any point in the level system because it's a threat, a known threat to the health of the other patients of the unit. But quarantine only at the higher 2 levels because of the potential impact and the higher chance that the quarantine person really might be positive.
Great. Well, I want to thank all of our panelists and Dr. Fetter for bringing these great cases so that we could sort of talk through some of the nuances and acknowledge the gray zones within infection prevention and control. I want to thank you, the audience, for joining us for the behavioral health session of our telementoring series, Building Blocks of IPC. We hope that you've learned from the discussion today and will join us again.